Hello friends, in this course we are going to discuss about the problems associated with assessment when an individual has the illness cognition and the assessment is done, but there are many complexities that may lead to problems with relation to assessment of illness cognition. So this dynamic system of self-regulatory model process suggests a model of cognition that is complex and intuitively sensible. But it also possesses problems for attempts at assessment and intervention. Maybe in a situation like if the different components of the self-regulatory model interact, should they be measured separately? If we take a situation, is the belief that an illness has no serious consequences, will that be called an illness cognition or a coping strategy? Then another situation, if we consider, if the different components of self-regulatory model interact, can individual components be used to predict the outcome, or should the individual component be seen as co-occurring? If we take a situation with this regard, we can see, for example, is the appraisal that symptoms have been reduced a successful outcome, or is it a form of denial? So when the individual processes are involved in self-regulatory model, the assessment can be difficult and it can be understood in the following ways that we are going to discuss now. In stage 1 of the self-regulatory model, that is interpretation, there can be certain problems associated with assessment. Like the symptom perception involves individual differences also in symptom perception. How, if we may ask? Symptoms such as temperature, pain, a runny nose, or the detection of a lump may indicate to the individual the possibility of illness. However, the symptom perception is not a straightforward process. For example, what might be a sore throat to one person could be another's tonsillitis, or whereas for a retired person, he might consider a cough as a serious problem, whereas a working person might take it lightly. He is too busy to focus on his cough. Now, there are not only the kind of perception that depends upon individual differences, but there are other factors within the individual that can also create differences in assessment. One of the factor has been pointed out by Skelton and Penbaker. It is called as mood. The role of mood in symptom perception is particularly apparent in pain perception, with anxiety increasing self-report of the pain experience. In addition, anxiety has been proposed as an explanation for placebo pain reduction, as taking any form of medicine, like example sugar pills also, may reduce the individual's anxiety and increase their sense of control and result in pain reduction. So the kind of mood that we are going through may also affect the way we assess our illness. Then the other important factor that can contribute in problem in assessment of our illness is cognition. An individual's cognitive state may also influence their symptom perception. Penbaker has reported that symptom perception is related to an individual's attentional state and the boredom and absence of environmental stimuli. That may result in over-reporting, whereas distraction, attention diversion may lead to under-reporting. So the kind of attention that we are paying to a particular situation, the feelings that we have, we are very bored about a situation, then that also affects whether we overestimate our sickness or symptoms of sickness or we underestimate them. And that can also lead to problem in assessment, accurate assessment of an illness in an individual. The other important factor beside the cognition, mood, is environment. Environment, like for example, the symptoms perception is also being basically affected by the environment. Here in the context of environment, we can say the social situation has to be considered as an environment, and this has been very famously been described by a condition known as medical student disease, which has been described by Mechanic. It is a kind of disease that many of the medical students suffer in the first year of their medical course. A large component of the medical curriculum actually involves learning about the symptoms associated with multitude of different illnesses, and more than 2/3 of the medical student incorrectly report that at some point of time they have had those symptoms and they are suffering from those illnesses. Perhaps this phenomena can be better understood if we put this phenomena in the form of mood, cognition and the environment that the medical student go through from. So, mood of the medical student becomes quite anxious due to their workload. This anxiety may heighten their awareness of any physiological changes and make them look more internally focused, and they pin out or pinpoint every single ache and pain and minor things that they experience. Other factor that can lead to this medical student disease is cognition. Medical students actually, they think a lot about symptoms. Because it is a part of their course, they keep on pondering about those symptoms, which slowly they may start internalizing in their own self and thinking that they are also suffering from that same illness. And the social aspect or the environmental aspect of the assessment is in the medical student. Once the student starts to perceive symptoms, other may model themselves on this behavior. So if a student says that I am showing this symptom and I am suffering through this illness, the other friends, the other classmates also may copy the same behavior, and they may also believe that they are also going through the same illness. Therefore, symptom perception influences how an individual interprets the problems of illness. Beside this, there is another important factor that may affect my symptom perception, that is called as social messages. Now, information about illness also comes from other people. This may come in the form of a formal diagnosis from a health professional, or a positive test result from a routine health checkup. Such messages may or may not be consequences of symptom perception. Like for example, a formal diagnosis may occur after symptoms have been perceived. The individual has subsequently been motivated to go to the doctor and has been given a diagnosis. However, screening and health checkups may detect illness as at an asymptomatic level of development, and therefore attendance for such a test may not have been motivated by symptom perception only. The other important social message that can determine that symptom assessment has been occurring is information about illness that may come from lay individuals who are not health experts actually. Before or after the consulting health experts, people often access their social network, or which can also be called the lay referral system. It has been shown by Fridson, lay referral system can form in the shape of colleagues, friends, family who tend to give advices to the person who is thinking that he or she is suffering through some symptoms. For example, if a person coughs in front of one's friend, the friend may give the advice to speak to another friend who has suffered from the same or similar cough symptoms. Or the friend may give some suggestions to take a home remedy. Alternatively, it may result in a lay diagnosis or a suggestion to seek professional help from the doctor. In fact, it has been reported that 3/4 of those who take part in the medical practices or go and seek medical attention has sought advices from family and friends before seeking professional help. So, social messages will influence how an individual interprets the problem of illness. Then if we look into the self-regulatory model's second stage, that is stage of coping, there also the assessment of illness can suffer through some issues and problems. So, the three approaches of coping that may suffer through issues and problems are as follows, that is coping with diagnosis, coping with the crisis of illness, and adjustment to physical illness, and the theory of cognitive adaptation. These different theoretical approaches have implication for understanding the differences between adaptive and maladaptive coping and the role of reality and illusion in the coping process. They therefore have different implications for understanding the outcome of coping process. So, if we focus on the problems associated with coping, let us first go to the first approach, coping with a diagnosis. Shantz has described the stages of coping that individuals often go through after diagnosis of a chronic illness. After the diagnosis of the chronic illness, the first problem or the first issue that the individual faces is shock. Initially, most people go into a state of shock following a diagnosis of a serious illness. Being in shock is characterized by being stunned or bewildered or behaving in an automatic fashion, and having a feeling of detachment from the situation. With the second, coping with diagnosis occurs when the person encounters a reaction. This is characterized by disorganized thinking and feeling of loss, grief, helplessness and despair. And the next stage that can occur is retreat. It is the process of coping with a diagnosis. This stage is characterized by denial of the problem and its implication and a retreat into oneself. So the person may retreat completely or may deny that he or she may be suffering through the problem. But it has also been pointed out by Shantz that retreat is the initial first stage to taking the reality into grasp and going for medical attention and help. So retreat may look like a negative stage whereby a person is denying that he or she is suffering through a problem, but after retreat the realization occurs that I am suffering through illness and I need to take medical attention. So this leads to our second approach in coping, that is coping with the crisis of illness. In an alternative approach to coping with illness, Morse and Schaeffer have applied crisis theory to the crisis of physical illness. Now, what is this crisis theory? Crisis theory has been generally used to examine how people cope with major life crises and transition, and has traditionally provided a framework for understanding the impact of illness or injury. The theory was developed from work done on grief and mourning and a model of developmental crisis at transition points in the life cycle. In general, this crisis theory examines the impact of any form of distortion on an individual's established personal and social identity. It suggests that psychological systems are driven towards maintaining homeostasis and equilibrium in the same way as physical system. So, with this respect, any crisis is self-limiting, as the individual will find a way to returning to a stable state, and that can also be applicable to the health condition. So the physical illnesses that are attributed to the crisis and coping with them follows the next stage. Morse and Schaeffer also argued that physical illnesses can be considered as crisis as it represents a turning point in individual's life. They suggest that physical illness causes the following changes that I am going to talk about, which are changes in identity. Illness can create a shift in identity, such as from being a caretaker, now I have become a patient, or from being a breadwinner of the family to a person with an illness who is dependent upon others. It can also lead to change in location. Illness may result one to move to a new environment such as hospital, or being bedridden from being the luxuries of home life. It can also lead to change in role. A change from independent adult to passive dependent may occur following illness, resulting in a changed role. It may also lead to change in social support, because illness may produce isolation from friends and family, affecting changes in their social support structure. And it may also lead to changes in future. Because of the illness, the future involving my life, my career, my family becomes uncertain. So all this can lead, and along with all these factors, there are additional factors that can create problem in the nature of illnesses to be assessed, which can be discussed as follows, such as illness is often unpredicted. If an illness is not expected, then the individual may not have the opportunity to consider the possible coping strategies. So if I am not ready for an illness, I will not be ready for its treatment. Then the other problem that may occur is information about the illness is unclear. When much of the information about illness is ambiguous or very confusing, particularly in terms of causality and outcome, then the person may have problem in assessment with the illness. Another important factor is a decision that has to be made quickly. So when the person gets to know that he or she is suffering from an illness, they have to make a very quick, drastic decision that may be life-changing or life-altering. Like, should we operate now? Or should I take medicine? Or should I take time off from work? Should I tell my friends or not? So these are major decisions that can affect my assessment of illness. The other factor is ambiguous meaning. Because of uncertainties about casualties and outcome, the meaning of the illness for an individual will often be ambiguous. Like, for example, is it really serious that this illness I'm suffering, or how long will it affect me? So when I'm not clear about the effect and the time, it may affect my assessment of the illness. And limited prior experience. Most individuals are healthy most of the time. So therefore, illness is infrequent and may occur to individuals with limited prior experience. This lack of experience has implication for the development of coping strategies and efficiencies based on other similar situations. For example, if we take like the person has never had cancer before, so how will the person deal, or what should be the next step of the person? So all this framework by Morse and Schaeffer has considered illness a particular kind of crisis, and that is why they have applied the crisis theory to illness in an attempt to examine how individuals cope with this crisis. Then we go to the next approach, the third approach, that is the coping process itself. Once confronted with the crisis of physical illness, Morse and Schaeffer describe three processes that constitute the coping process. That is cognitive appraisal, the adaptive task, and the coping skills. Let us elaborate on these three crises. Process 1 is cognitive appraisal. At the stage of disequilibrium triggered by the illness, an individual initially appraises the seriousness and significance of the illness. For example, is my cancer serious? How will my cancer influence my life in the long run? Will I stay alive? Will I be with my family? Factors such as knowledge, previous experience, and social support may influence the appraisal process. In addition, it is possible to integrate Levinthal's illness cognition at this stage in the coping process, as such illness beliefs are related to how an illness will be appraised. The next process is adaptive task. Following cognitive appraisal, Morse and Schaeffer describes 7 adaptive tasks that are used as part of coping process. These can be divided into 3 specific tasks and 4 general tasks. The 3 specific tasks that has been described are, the first one is dealing with pain, incapacitation, and other symptoms. This task involves dealing with symptoms such as pain, dizziness, loss of control of body organs, and the recognition of changes in the severity of the symptoms. Like, I am becoming day by day sick, so I should be dealing with the symptoms, or else I'll be completely handicapped. Or the second task is dealing with the hospital environment and special treatment procedure. This task involves dealing with medical interventions such as mastectomy, chemotherapy, and other related side effects that will hamper my normal day-to-day activity. So, how am I going to deal with them? Am I going to take them positively, or am I going to sulk and become negative about them? The next task is developing and maintaining adequate relationship with healthcare staff. See, becoming ill requires a new set of relationship with a multitude of health professionals. You might be visiting many hospitals, you might be giving many visits to the doctor, you might be doing many diagnoses. So thereby you need to form a relationship with them so that they communicate, there is a proper communication channel where your doubts are cleared and you have proper medical treatment. And this task describes the development of those relationships. And those relationships are significant in the treatment processes to be followed. The next 4 general tasks that has been described, the first one is preserving a reasonable emotional balance. This involves compensating for the negative emotion aroused by illness with sufficient positive ones. So, I am sick, I am helpless, I am going to be handicapped. These are all negative emotions. Now I have to replace them. Though I am sick, I have to fight back, I have to fight my illness, I have to become healthy, and even though I may suffer with some repercussions or side effects, I am going to overcome them with the emotional support that I can gather from my family, or I will have the motivation myself to face that problem. The next general task an individual can follow is preserving a satisfactory self-image and maintaining a sense of competence and mastery. This involves dealing with changes in appearances following an illness like disfigurement of the face or the body parts. So dealing with that, maintaining oneself's image as positively as possible is a very pertinent, important task. And adapting to a reliance on technology, like adding a pacemaker or taking a hearing aid, can be affecting our self-image in the beginning. But if the individual sees the positive side, because of the pacemaker I am alive, because of the hearing aid I am not going through the embarrassment of not hearing others, those kind of inputs, mental cognitive inputs, can help the person empower his self-image. The third general task that an individual can do is sustaining relationship with family and friends. This involves maintaining social support network even when communication can become problematic due to changes in location and mobility. So maybe the individual is hospitalized and is away from the family, but still there should be communication between the family members and the individual who is suffering so that he gets the social support. And the individual can develop relationship within the hospital so that he gets positive social support from the members in the hospital and maintain his cognition at the best. Then the next stage is preparing for an uncertain future. Illness can often result in loss of sight, lifestyle, mobility, or physical handicap, and they involve a lot of effort from the individual. This task involves coming to terms with such losses and redefining the future. My life has altered forever. Now I have to make the decision to bring those changes into my life and move on. So these are the important tasks that an individual has to face when it comes to serious illnesses. Then the next process or the next stage, coping skills. Once the individual has cognitively identified what he or she is supposed to do, the next step follows is the use of adaptive task. Morse and Schaeffer again has described a series of coping skills that are assessed to deal with the crisis of physical illness. These coping skills can be categorized in three forms. One is appraisal focused coping, the next one problem focused coping, and the last one is emotional focused coping. Let us discuss about what is appraisal focused coping. Appraisal focused coping involves attempts to understand the illness and represents a search for meaning. Three sets of appraisal focused coping skills have been defined actually. They are logical analysis and mental preparation, that involves turning an apparently unmanageable event into a series of manageable ones with analysis, logic, that if I am sick, I have to take treatment, there is no other go. Then the other one is cognitive redefinition, involving accepting the reality of situation and redefining it in a positive and acceptable way. So not only am I suffering through the illness, I may be affected by it negatively, but that is the reality. I have to accept it and move on. And the next one is cognitive avoidance and denial, involving minimizing the seriousness of the illness, thus by neglecting or ignoring the illnesses as such. Now, how much will that help in assessment and treatment is questionable. If it is a minor illness, then denial actually can help in maintaining the mental peace as such. The next stage is problem focused coping. It involves confronting the problem and restructuring it as manageable. There are three types of problem focused copings, such as seeking information and support, involving building a knowledge base by accessing any available information, talking to the experts, getting online and finding the information about the illness the person is suffering from, and so that making yourself more knowledgeable and more ready to face the challenges of that illness. The other one is taking problem solving action, involving learning specific procedures and behaviors, example, how to take insulin injection, how to take the medicine, how to understand the components of the medicines, what kind of effect they have on my health, how much of the dosage I should take. All those involves the problem solving action. And the next one is identifying alternate rewards. It involves the development and planning of events and goals that can produce short-term satisfaction. So if this reward fails for me, this treatment fails for me, I can do something else. If that fails, I have to do something else. So always keep the options open so that we are benefited the most when it comes to treatment of illnesses. The next stage is emotion focused coping. It involves managing emotions and maintaining emotional equilibrium. There are 3 types of emotional focused coping which has been found in the coping skills. They are affective, involving efforts to maintain hope when dealing with a stressful situation. The next one is emotional discharge, involves venting feelings of anger or despair. It's better to vent out your extreme emotions when an individual is suffering from any form of serious illnesses. The next one is resigned acceptance, involves coming to terms with an inevitable outcome of an illness. Accepting that I have a chronic illness or I have a deadening illness that may affect my life or that is going to change my life. So instead of denial, instead of getting frustrated, aggressive, let us accept it and move on. And whatever days I am left with, I should leave with happiness. Therefore, according to this theory of coping with the crisis of a physical illness, individuals appraise the illness and then use a variety of adaptive tasks and coping skills which in turn determine the outcome. Not all individuals respond to illness in the same way. And Mosen Schaeffer has argued that the use of the tasks and skills is determined by 3 factors. First one is demographic and personal factor. So my age, the individual's age, gender, class, religion can also affect the way they respond to an illness. Then the other factor is physical, social and environmental factors such as the accessibility of social support network and the accessibility of physical environment. And the next one is illness related factor such as any resulting pain, disfigurement or stigma associated with illness. I have got an illness that is contagious, so people will run away from me. So I am embarrassed about it. Should I hide? Should I disclose others? Should I, keep away myself from others? So all these factors also can affect the way I respond to the illnesses that I'm suffering from. So if we want to conclude, what is the way we can reduce the problems in assessment, it has been seen that within this model of self-regulatory structure, individuals attempt to deal with the crisis of physical illness via the stages of appraisal, the use of adaptive task, and the employment of coping skills. The type of task and skills used may determine the outcome of this process, and such outcome may be psychological adjustment or well-being, or may be related to longevity or quality of life per se. But according to the crisis theory, if we consider, individuals are motivated to re-establish a state of equilibrium and normality. So it's not just I'm sick and now I'm healthy, but it is the normality in my whole life. I want to be mentally peaceful that sickness is gone forever and now I can lead a normal life. This desire can be satisfied by either short-term or long-term solutions. So if I have a minor illness, I will take a short-term solution and my illness will be gone. But if it is a chronic illness, then I have to take a long-term solution of dealing with the illness or fighting with the illness. So crisis theory actually differentiates between 2 types of new equilibrium. One is healthy adaptation, which can result in maturation, and the other is maladaptive response, resulting in deterioration. Within this perspective, healthy adaptation involves reality orientation and adaptive tasks and constructive coping skills. Therefore, according to this model of coping, the desired outcome of coping process is actually healthy adaptation and reality orientation. So once the person is oriented towards the reality of his life, he can assess them, he can adapt, he can change, and he can use the coping skills for betterment of his health. So with this, we conclude the course. Thank you.